Thank you. So good morning, everyone. I'm Paola Pascali, researcher at the Essex County Council.
Hi, everyone. I'm Jyotsna, public health analyst at Essex County Council. But I also have a personal interest in this because I used to be a practicing dentist. Very exciting to present exciting things happening in the world of dentistry today.
Yeah, and today we are going to present our first oral health need assessment. Before we, okay, yes. Okay, before we start, in case you are wondering where Essex is here. We are a local authority that serves more than 1 million of residents, and we are in East of England. So a quick overview of the presentation of today. So we will go into a basic introduction about what the oral health assessment is and why it's important. After that, we will present our key findings from the epidemiological study and the qualitative study that we conducted. And most importantly, at the end, we will go through the dissemination, how we disseminate our finding, and what impact this project had on our local authority. So about the introduction. Okay, yeah. So what is health need assessment and why is important? So health need assessment is a systematic way to look at health issue facing a population. Is also important because help us to leading and to agree around priorities, resource allocation, and in general improve the health and reduce inequality. We can say that it is considered an important tool to plan services and address inequality in the overall population. And why we decided to do our health need assessment? So last year at the end of, I think, April, we finished our statutory joint strategic need assessment, but we noticed that we have a huge gap in the oral health. And okay, yeah, and why oral health we believe is important. So usually oral health is a little bit underestimated, but actually poor oral health is a key indicator of the overall health and well-being and also the quality of our life. Is also influenced by the wider determinant of health. So here we collect some key facts about the poor oral health. For instance, did you know that poor oral health is associated with other diseases such as coronary heart, poor diabetic control, adverse pregnancy outcome, pneumonia in older people, and obesity. On top of that, poor oral health costs to the NHS 3.4 billion per year. For children, 2 decades result in 60,000 days being missing from school. So yeah, let's go. Before we introduce all our findings, we also have a quick look at the data sources. So for this study, we conducted, first of all, a literature review where we review local and national policies on the oral health and improvement. After that, our epidemiological funding comes from secondary data from Public Health England, our official national statistics. And as I say, we also conducted a primary research. So we had a survey and then in the interview. Yeah, next.
So now I just go through what we found in the literature and the results of our descriptive epidemiological analysis. So in terms of analysis, what we did was very simple. So we did a lot of descriptive epidemiology and then found out which districts were doing poorly, which was doing well, which had poor outcomes. So it's very simple. And so let's look at what we found in the literature. So you might think that oral health is not really very important, but did you know that nearly 100 systemic diseases and 500 medications have oral manifestation? So what we did was we looked at the literature on oral health inequalities and analyzed it using the framework of our county rankings model. by the Robert Wood Johnson Foundation. So the image is there on the slide. So what it basically means is your health is sort of depends on your health behaviors, your socioeconomic factors, clinical care, and the built environment. So if you look at the framework of oral health, look at the health behaviors like alcohol use and smoking. So heavy drinkers and smokers are 38 times more likely to develop oral cancer. And if you look at socioeconomic factors, you see that admission rates for tooth extractions are 4 times higher in the most deprived communities. And not only that, like Paola explained, they share lots of modifiable risk factors with non-communicable diseases like heart diseases, cancer, and stroke. So there is something in dentistry called as the common risk factor approach. So what it really means is you target those risk factors which impact a large number of diseases. So it's sort of like it creates an impact on a large number of diseases, better use of financial resources, more efficiency, and more effective. So now let's look at epidemiologic findings. So I made the slides like very simple, and it's just highlights which district is the worst compared to England and Essex average. And if you're interested in how all of the districts in Essex do, I'm very happy to share the link for the full report. So it's publicly available, it's on open data, Essex open data. So happy to share that. So before we go any further, let me give you a quick dentistry 101 lesson. So your teeth has 3 layers. There is the enamel, there is the dentine, and the pulp. So tooth decay actually starts from the enamel and goes deeper, deeper, deeper to the pulp. And when you go to the pulp, it's painful, needs invasive treatment like root canal treatments, and it's really expensive and not nice for children. So Colchester comes up on top here, having the highest percentage of children with decay enrolled in the pulp. And incisors. So your incisors are the front teeth, the front teeth you see when you're smiling. And they are smooth surface teeth, and if you have a lot of decay in your incisor, it just is very indicative of poor oral hygiene habits and poor eating habits. So Colchester comes up on top again, having the highest percentage of children with incisor caries, higher even than national and Essex average. Next slide, please. Yeah, so plaque is a sticky biofilm that forms when you eat anything, and over time plaque hardens and starts inflaming your gums. So Brentwood and Basildon is on top here, having nearly 5 times higher substantial visible plaque than England and Essex average. And finally, extraction due to tooth decay, which is essentially happens when there is a lot of pain, a lot of infection, and Harlow is on top here, having the highest percentage of extraction due to tooth decay, nearly 2.5 times Essex average. So now we know what the literature says, we know which districts are faring poorly, but that's just one side of the story. We needed to find out what our residents think. How do they find accessing services? Are there any barriers? And that I'll just quickly pass it back to Paola.
Thank you. This is very fun. Is this one? Probably it's better. Yeah, it's not working. Okay. Yeah, so as Jyotsna say, like we analyze all the literature review, we see all the epidemiological data. We also try to say, let's do a primary research, let's say what like our residents think in terms of like accessing the oral health need assessment, the oral health, services. And so this is a powerful quote from our residents. So NHS dentists, are like unicorn, but let's find a little bit more. Before I go to the main result, a quick intro on the methodology. So as I say, we use a mixed method. We did an online survey. The survey was let's be honest, our tools to recruit participants for our in qualitative study. So at the end of the survey, we asked if people, residents want to be involved in a one-to-one in-deep 1 hour in-deep interview. And after that, we recruit participants from the in-deep interview, and what we ask through the survey and our in-deep interview, we use a framework. So all the Essex resident experience with the oral health services were captured using this 5 domain of availability and accommodation. So that means that we ask like what they think about the opening hour and the number of NHS dentists in Essex. We also ask about cost, so affordability. We also ask about appropriateness, so the quality of the services they receive, the acceptability. So we ask about cultural and social factor, and approachability. If it was easier for them to find information about our services. And here we have like the central finding, as Jyotsna say, are a little bit limited. Like today we are just present like the main one. So we can say that the quality data from the survey and the deep interview show that the main barrier of the oral health services are related to the accessibility. We identify 5 themes. We use thematic analysis. So the first theme is about like long waiting time and booking system. So that means that our resident experience long queue over the phone to book an appointment, but on top of that, also they have like a long waiting list to have an appointment. And another like theme was about difficulties in getting an NHS dentist. So some residents experienced the registration, especially during the COVID. And because like it's so difficult to find an NHS dentist, they also go to the private healthcare to overcome the gap in the NHS dentist. Regarding like another thing was regarding the dental surgeries opening hour. So especially for like residents that work full time, it was very difficult for them. It's very difficult for them to have like an appointment that is compatible with their working hour. But most importantly, like family with children also have problems because they have to wait the school holiday to book an appointment for their children. And another huge theme was about the cost and affordability. So residents feel that there is an high cost of private dental care. And they also feel that like dental care is not respecting the NHS value of free care. And for this reason, like because they go to the private sector, they also have a huge effect in their finance. And in a moment as the moment we are living, the cost of living crisis is something very important. And the last one is about the poor quality of care. So some residents say they don't have enough information how to access an NHS dental services or an NHS dentist. They have the feeling that like the dental checkup are very poor and limited services. And also for some residents, especially like people with disability, they feel like the service is quite limited and not respecting their like needs. And so here we have like more than a couple of like quotes from our residents. As you can see, there is the NHS, are like unicorns. Another like quote I would like to highlight is like, I'm lucky because I found an NHS dentist who takes NHS patient and I stuck with them. So this is not the only quote that we have from residents. They use the word lucky. So the feeling is like, if you have an NHS dentist, you are lucky. So this was something that was nice to highlight. And now, do this again.
Right. We did a lot of analysis. We found a lot of great insights. So even though they were very simple, small analysis, they're very keen not to like let it sit and gather dust on the shelves. They're very proactive in telling people about it and telling interested partners about it. So just a quick look at what we did. So we did a lot of something called show and share, which is essentially something we do ECC wide. So you can tell other teams, say, for example, education or health and well-being. So all of them about this project and what you found. So we also disseminated the findings to senior management and heads of services. We also took it to partners in integrated care boards. We also did an NHS community conversation webinar, which was very well received. We also linked in with the East of England dental public health consultant to have her thoughts. and which was also really good, like collaboration. And we're also really proud of this. We released a blog on World Oral Health Day, ECC wide, and to sort of like tell people about the importance of the project and what we found. The next one, I'll just quickly go over what came out of this. So these, if you would remember from my slide, so these were the areas which we identified as areas of concern. So there is Colchester, Harlow, Basildon, and Brentwood. So what happened in Colchester, Harlow, Basildon, Brentwood was very similar. So we presented it to the integrated care boards perspective. So Suffolk and Northeast Essex ICB, Mid and South Essex ICB. And after presenting it to them, so the public health team in Essex County Council wrote a bid in partnership with Community Dental Services Essex. So after the bids was written out, there was funding allocated for a supervised toothbrushing program, a peer education program, and a resource funding for classes. And so after getting the funding, so we were also very keen that we need to take a data-driven approach. So what we essentially did was we took the small area dental caries rates, overlaid it with obesity in children, and also overlaid it with depression. So essentially, we ranked wards which have high deprivation, high dental caries rates, and high obesity. So after doing that, we essentially mapped them and looked at childcare settings and primary schools in those areas. And then we had a list. So we actually called them and offered the toothbrushing program to those settings. So this was essentially what's happening in Northeast, so Colchester, Basildon, and Brentwood. So this funding was for 3 years. And what is happening in Harlow, I would say, is a more ongoing journey. So Harlow is an area of significant disadvantage, and it is one of the leveling up areas in Essex. So there are alarming increase in poor oral health outcomes. So again, we picked out key findings from the needs assessment to essentially tell a story to interested partners. And we are very keen to bring in partners with local knowledge. So people from the respective integrated care boards, from district and borough council, from primary schools, from Harlow College. So what happened was that we had a lot of interesting conversations. So because of the different spectrum of people represented, so they were really sort of innovative and bringing sort of lots of collective solutions. And, you know, because of all these sort of like people with really good passion for improving health outcomes in children, so we're just starting to collaborate with each other, share data with what we have, and, you know, find bids and see what we can do together. So this is exciting, and this is a more ongoing journey. So that's what happened. So let me summarize it. So we found several areas of concern from this needs assessment. So there's Harlow, Basildon, Brentwood, Colchester. And these areas have a pattern. So they have higher deprivation and higher unhealthy eating habits. And although our survey data is exploratory, we used secondary data from samples to drive policy decisions. And really proud to present this project because we feel that this is a really good example of using data to tell a story and drive decision making. And not only that, this highlights the need for partnership working and bringing people who know their patch and, you know, sort of bring them so that we can come up with collective solutions together. And thank you so much for listening. The full report is on Essex Open Data. And if you have any sort of questions or comments and you want to get in touch with us, there's an email, so please feel free to get in touch with us. Thank you so much.
Thanks so much, Jyotsna and Paola. Does anybody have any questions?
Yeah, hi. So I'm from Manchester Council, so we've just done a very similar piece of work to yourself. We've just kind of shared some findings for that. I think one of our main findings was the lack of any substantial local data to identify inequalities. You know, so you mentioned kind of oral health programs at ward level, so I'm interested to see how you get on with that, but so the kind of lack of any information on inequalities, both by areas, by communities, and kind of when they've identified a similar issue, and so how you overcome that, or how you plan to overcome that.
So essentially this one, so the oral health survey of 5-year-old children, so it has the district level. So I got in touch with their team, so they actually had ward level data, and we essentially had to sign the data sharing agreement, and it took time, and then they gave us, but that had levels at ethnicity and deprivation, so that's quite helpful, so you could sort of check out if you're interested.
You can welcome to be, because I am not very.
Yeah, it was a bit slow getting there, but
They give it to you.
I was just interested in when we didn't get identified private schools in the affected areas of childcare settings. How you went about engagement with them and how it was received by them, your offer of the two-push program.
I would say it was well received, but it was also because the team, so we had a team that sort of had a very good working relationship with that, and so that made it sort of easier and gave a better in. And there was also a program, so a similar program which is running in a different district, so sort of like leverage on those contacts and sort of use that.
And did you do that alongside the Royal Universal in
No, only targeted offer, yeah.
Oh, yeah. I was just wondering if you come across any insight or evidence about kids with special education needs.
No, unfortunately, that was too big a scope for us to look at, so we did not look at that, fortunately.
I must admit, I didn't really pay any attention to dental data, not really ever been looked at. But yesterday in the business, NHS Business Authority, they showed their new DI dashboard around dentistry, and really shocking the access to care, the support, especially when you look around 420, and it seems for me like this huge area of inequality. I know at the end you had 10 which has got the most deprived ward in the country in it, and it got kind of thinking first of all about the idea about, first of all, with this it feels like there's so many unknown unknowns because people are accessing services that we can't measure whether or not their outcomes are any good. So therefore we maybe need to be relying more on models, forecasts, and some form of actually looking at all that unrepresented information that's out there, because I don't think even your graphs are showing a clear picture of actually the realities of what's out there.
Yeah.
What I'm really interested in is what I noticed in your engagement was just a distinct lack of dentists being engaged.
Yeah.
I mean, you know, I'm gonna say this as a parent, not as a civil servant or someone who works in the industry. What are they doing?
Do you
Yeah,
want to take this?
like when we designed the survey, we have like one survey for like residential, one survey for the dentist, just to have also the point of view, and basically we didn't get like good results, and also they never engage with us or have any follow-up interview, because like we stop our like primary research at qualitative research, and the reason why they told me, few of them, they told me like that 1 hour interview was like too long, they're very busy,
On the golf course.
so it was like
It's absolutely disgraceful.
yeah.
It's the moral stance alone is absolutely disgraceful.
Yeah. I think we are really, with Harlow especially, we're making an effort to start like engaging with dentists from the get-go, to before we start you know, making any programs or like engaging like outreach. But it's hard, like you said, it's been like really hard.
Even lawyers do pro bono. Even estate agents do pro bono work, you know.
But due to the actual nature of dental contract, means they don't get paid, say on TV, they don't get paid for their patients, they get paid for what they do. So actually, there's no data on who they see. The data is what they do, and that's an issue in the contract.
Yeah.
So they don't have lists, and then when GPs do without responsibility for care for their patient list, they don't have a list. It's the experiential contract, which the national came out 10 years ago, more.
And also, like, I didn't put this on the slide, but I can highlight that one of the biggest problems that our residents had, that they did not know if the dentists were accepting patients or not. And that is also apparently something very temporal, that if they need to hit more targets, so they would just open their doors and sort of take in more patients. So it was really hard, and that was something that frustrated our residents a lot.
And they were very lost, they told me like, we don't know how to, where and how to find information, who takes NHS pension, and we know, not, and some people say because like the cost of our health is very high, and we don't have an NHS pension, basically we don't do anything, so we will keep the pain or we will not. It's not something, yeah, exactly. And they were very like, how can I say, also not upset, but say why. I remember a resident told me, why if you like have any other problem, such as like problem with your heart, like NHS provide you care, and when it's come to heart health, they don't care. Like, yeah, it's very hard to easy.
I was just wondering whether my ambivalence to the data is also reflected as wider part of actually a system ambivalence to everything. You know, everything that you said at the front, we relate that to cancer, diseases, and most modifiable risk factors. There seems to be activity or action around it, a call to arms, but I don't see it with dental and all of that. I mean, maybe it's there, but I haven't seen it.
Right, that's sorry, one last.
You brought out one case. Just a quick question about supply, I guess, actually. We've done some work for West Midlands ICDs on primary dental care. And the real issue there's no data on private provision as well, other than they're on.
That's true.
And even NHS contracts with an average, they do with private on top of that. So if you looked at kind of attitudes of populations to private dentistry and sort of accessibility in terms of cost of dentistry and where those services might be.
No,
Triangulating the median.
no, but this is actually a good like idea, to be honest, like because from our like like funding that some of them say that they go to the private to overcome the gap. So yeah, it is something.
Yeah,
that
we could explore this.
Yeah, it was
So
a very.
so that's got a section of dental services, which
Yeah.
about how these funds need to model through
Yeah.
people's attitudes and perceptions and behaviors.
Thank you. It's a very good comment. Thank you.